please welcome Dr Michelle White.
Thanks, KP. I'd first like to thank BCNA, KP, Vicky, Anna and the whole team for asking me to be involved in this forum. I've done a few of these now. They're the most uplifting, joyous experiences. I know they can be confronting at times, but I feel very lucky to be involved. So I'm a medical oncologist. I subspecialise in breast cancer, and I work both in the public and private setting, which I think is a nice mix to have. I call Hobart my second home. I've already been to Pigeonhole this morning, had a very nice coffee, so I love being here. So today it's my pleasure to present on the current and emerging treatments to support living well with early stage breast cancer. Now, I really hope this is a bit interactive. Please don't wait to the end if you've got a question. Really happy to be interrupted. I think it works better that way. And if you disagree with anything I say, please call out. So, as we know, breast cancer is a common illness. 1 in 7 women in Australia will develop early stage breast cancer. And while it's much less common, men can also develop breast cancer. And the most important message I hope that you take home from today is that the vast majority of patients diagnosed with early stage breast cancer in Australia will be cured of their illness. It's not 100%, and until that's the case, that's unacceptable, but really the odds for most patients are very good. I'm just going to do a very brief biology lesson. The image on the right is what we call like a cross-section through the breast, and you can see moving backwards from the nipple that there are the ducts leading into the lobes of the breast, surrounded by the fat tissue. And when we talk about the subtypes of breast cancer, it can be related to what part of the breast has developed breast cancer. One of the most common questions patients will ask is what is the difference between DCIS, or ductal carcinoma in situ, and invasive breast cancer? And I'm hoping these images might help explain some of those differences. The image on the left shows a normal breast duct, where you can see the cells are very neatly aligned around the edge. And the image on the right of that same left-sided image shows where there's overgrowth of those cells. So there's too many that should be there. However, they are located and contained within that duct. The image on the right is showing us the next step, where the cancer cells at the bottom image, known as invasive breast cancer, have worked out how to jump out of that duct and spread to other parts of the body. And so the difference between the two scenarios is that while ductal carcinoma in situ is a serious diagnosis and does need to be treated, on its own it doesn't become life-threatening until it potentially becomes an invasive cancer. The term breast cancer is quite a broad term, so there are many different illnesses within the term breast cancer. Some patients want to know a lot about their illness, and other patients really don't have much interest at all. And again, it's part of my job and the treating team's job to find out from the patient how much they want to know. The most common subtype arises from the ducts of the breast and gets the poor tragic name of no special type. So it used to be called invasive ductal carcinoma, now it's called NST. The second most common is what's called invasive lobular cancer, so you can see that develops from the lobules within the breast. It behaves quite differently to the NST subtype, and it's important we know if that's the subtype of cancer a patient has, because the treatments may be influenced by that. And then there's a whole lot of much rarer subtypes of breast cancer that I'm not going to go through today. One of the most common questions patients will ask when they're diagnosed with breast cancer is, why has this happened to me? I think I'm leading a pretty healthy life. I'm not, doing anything wild or crazy, and yet this has happened. And really, in 2024, the two most common reasons that a woman will develop breast cancer is that she's female and she's over 50. And that's not really a very acceptable explanation, but that's about all the information that we have. There are a whole lot of risk factors. So The area in the white is things that increase your risk of breast cancer, and the grey area down the bottom is protective factors. And the most important thing I really want you to take out of this is that while there are a whole lot of factors that may have a slight impact on your risk, really, apart from carrying a gene that increases your risk of breast cancer, like BRCA1 or BRCA2, which very significantly increases your risk, most of the other factors have a pretty minor effect, and maybe for most people, it's a whole lot of these factors all at play that result in their development of breast cancer. So I kind of imagine for many patients, there are a whole lot of things that on their own would not cause the breast cancer, but when they're all joined together, do cause the breast cancer. There is definitely something about Western life that increases risk. So there is a lot of research looking at this at the moment. Let's talk about how people present with a breast cancer. So a significant proportion of patients will present through breast screen. So they'll go for their standard mammogram, and even though they haven't felt a lump, some suspicious changes will be seen on a mammogram, and ultimately the patient's diagnosed with an early stage breast cancer. But sometimes patients do feel a lump, and as we all know, we're encouraged to see our doctor if we develop a lump in the breast. Sometimes it'll turn out to be nothing, but it's very important to have those investigations done. And sometimes just a routine doctor examination will pick up a breast lump. We are lucky in Australia to have access to breast screen, and any woman over the age of 50 is entitled to have her 2 yearly mammograms and ultrasounds done. And indeed, women who are younger but have a family history of breast cancer are also eligible for mammography. There are new types of scans coming through, which is good because a mammogram, while an important test, is a bit of an unpleasant test for many patients, and some patients do avoid it because, it's uncomfortable. MRI scans moving forward are certainly offered particularly to young patients who might have very dense breasts and those that carry a high risk of breast cancer, such as carrying the BRCA genes. For those women, they are reimbursed, but for other patients, they'll be a very expensive test. So typically a breast surgeon would decide who needs that sort of investigation. And finally, contrast mammograms are a new exciting test coming through. Like when you have a CT scan, they inject contrast and then they quickly whip you over to the mammogram machine and do their mammogram, and the images they get are really, the definition is really, really good, and it's certainly, I think, over coming years will replace a standard mammogram. Yeah.
You just said that you're entitled to have 2 mammograms and ultrasound per year.
No, 2 yearly.
2 years.
Every second year. No. That's okay, sorry if I didn't make that clear. Once we've got a scan that's showing a suspicious change, we do need a biopsy. And the reason that we need a biopsy is we really need to sort out what kind of cancer this is. Is it DCIS or is it an invasive cancer? And if it's an invasive cancer, what subtype is it? Is it this NST type or lobular or one of those rarer types? How fast is it growing? Grade 1 tumours tend to be slower growing tumours, and grade 3 tumours, that's as fast as they get, grade 3, tend to be the fastest growing. And as we're going to talk a little bit about today, the most important information really for the treating team is what's driving the growth of this cancer. Is it hormone positive, which means it's either got the estrogen or progesterone or both receptors on the surface? Is it what's called HER2 amplified, which means it's driven by a particular protein that can be found on a cancer cell? Or is it triple negative, where none of these gates are present? The little cartoon on the right is showing you a cancer cell with that is hormone positive. It's got a little estrogen gate on its surface, and the yellow ball is the estrogen, is the hormone binding to it, stimulating. The message is going straight to the little purple area, which is the nucleus, telling the cells to grow. And the little image down the bottom is where this patient's on a hormone blocker. So even though there is a cancer cell, the blue ball, which is the hormone blocker, is preventing the growth being driven by that little gate, and the cancer cell should die. This image is telling us about the subtypes of breast cancer and some of the characteristics and treatment options that we have. So starting down the bottom, triple-negative breast cancer, as I've said, is a subtype that doesn't have estrogen, progesterone, or the HER2 gates on the surface, tends to be a fast-growing cancer, and tends to be grade 3, so that real fast-growing type of tumour. HER2 positive is the next subtype. They can either be hormone positive or negative, and they can be sort of faster growing or slower growing. And then the top two groups are what we call luminal breast cancer, and that's hormone positive breast cancer. So a hormone positive breast cancer can either be luminal A, means it's really slow growing, very sensitive to hormones, or a luminal B, where it's still hormone driven, but can be a bit more aggressive. One of the most important determinants of the treatments we're going to talk about for a patient and the outcome for that patient is the stage of their cancer. So the stage is really meaning how far has the cancer spread. And I'll just go through the different stages. Stage 1, as you imagine, is the earlier stage. So the cancer is small and it's restricted to the breast. Stage 2, the cancer's either bigger, often over 2 centimetres in size, or there's involvement of lymph nodes. Stage 3 is a much bigger tumour and often quite extensive lymph node involvement. And stage 4, or metastatic breast cancer, is when the breast cancer has spread either in the bloodstream or the lymphatic system and has spread to other parts of the body. And obviously that's a different scenario where the goals of treatment are to try and help the patient live as long as possible, whereas for the other 3 stages, we're really trying to cure the illness with our treatments. So as I've said, really what we want to establish is what type of breast cancer is it, what stage is it, and then we need to work out what's the next best steps in a patient's treatment. So for most patients, the first step will be an operation, and that might be a lumpectomy or a mastectomy, and I'll discuss in a minute why we decide either of those 2 ways. And also getting an idea, has the cancer spread to the lymph nodes? So if we don't think it's gone to the lymph nodes on all our tests, we'll do what's called a sentinel lymph node biopsy to minimise the number of lymph glands we remove, to reduce the risk of lymphedema. But if we think the lymph glands are involved, then more lymph nodes and axillary clearance would take place. However, for some patients, we now swap the order around, and rather than doing the surgery first, we're giving preoperative, or what we call neoadjuvant treatment. And this is particularly the case for some subtypes of breast cancer. So as I've mentioned, the standard would be to start with your surgery, either a lumpectomy or a mastectomy, and then consider additional, or what we call insurance policy treatments, to try and minimise the risk of that cancer returning. And those treatments might be chemotherapy, immunotherapy, targeted treatments, endocrine therapy or hormone blocking drugs, and radiation treatment. So patients will often say to me, well, how did you work out which treatments I needed? And we are blessed in Australia that multidisciplinary meetings are considered standard of care for all patients diagnosed with early stage breast cancer. And essentially what happens at those meetings is that typically the surgeon would present the patient, and then the pathologist would show us, I always say to the patient, I've met your cancer, I've seen the images of your cancer, and then we look at the scans and look at whether the lymph glands are involved. Often the breast care nurses might have already met the patient and will tell us some of the social aspects that are relevant for that patient. And then as a group, we make recommendations about what we believe is the right treatment for that patient at that time. Now, sometimes there's strong dogmatic recommendations, and sometimes patients fit into what we call like a grey zone, where there are treatments they could have, the benefit might be small, and the patient is involved in that decision-making process. And we've already heard today that, patients do have a voice in decision-making. A doctor can always tell you what they believe is the right thing to do, but the patient also has an opportunity to present what they feel they would consider or would not consider. Patients will often say to me, well, Michelle, what would you do if you were in my position? And I have a standard answer to that really until I'm sitting in that chair, I don't know what I would do, because, until you're in that circumstance, you really can't be sure. Probably, err on the side of more treatment just because of my background, but I really don't comment because I don't know what I would do in that circumstance for that patient. So as I've said, sometimes the recommendation from the group will be to have chemo and targeted treatment or immunotherapy first. Now, some patients struggle a bit with the idea of you leaving the cancer there and getting on with treatments. But once they start to feel the lump melting away with the treatment, they often feel quite differently about it all. So the subtypes of breast cancer where we tend to give preoperative treatment are the HER2 positive and the triple negative groups. And I have literally seen cancers that are, 5 or 6 centimetres in size be completely gone by the time the woman or man has an operation with preoperative treatment. We also have to make sure that we put the clip in at the start, because sometimes if the cancer's gone, the surgeon, doesn't even know where to go. The responses can be so dramatic. Not for everyone, but they can be very, very impressive. We don't often give chemotherapy preoperatively for a hormone-positive breast cancer, mainly because we don't tend to see a lot of shrinkage, and also that, if it's not going to change the type of surgery or anything like that, it's not in the patient's best interests. So the advantage of giving it for the HER2 positive and triple negative is that, as I've said, sometimes we completely destroy the cancer. It can sometimes allow a patient who initially was going to need a mastectomy to have a lumpectomy if the lump shrinks a lot. And also the response may help us work out what additional treatment the patient needs after the operation. So for patients with triple negative disease, we tend to give preoperative chemo with something I'm going to talk about in a minute, something called immunotherapy. For those with the HER2 amplified cancers, we give chemo as well as these targeted treatments that target that HER2 gate. And for hormone-positive patients, typically, if we're going to give it, we give chemotherapy, but there's more and more interest in giving preoperative hormone blockers to patients if there's a need for time to sort out what, the surgery or genetic testing or other aspects, or if the patient's got other health issues that need to be addressed before we can operate. So that's neoadjuvant treatment. The other term you'll hear commonly used is adjuvant treatment. So adjuvant treatment is given after the operation. So the surgeon has removed the breast cancer, we've had a look at the lymph nodes, but what we do know is that breast cancer can sometimes be a very tricky little bugger, and cells can have leaked from the breast and spread to other parts of the body, either in the lymphatic system or the bloodstream, sit there dormant for years and later form stage 4 breast cancer, which we've already discussed is what we're really trying to avoid if we can. And so all the treatments we're talking about now are to try and make that risk as small as possible. And so these are called adjuvant treatments. Patients will sometimes say to me, Michelle, well, how do you know I need this treatment? Maybe Mr. So-and-so's operation has removed and cured me of cancer. In 2024, we don't have a clever way of a blood test or something else that says this individual patient needs more treatment and this patient doesn't. And so many patients get treatment, but we'd rather be safe, than a patient presenting with stage 4 disease down the track. And the sort of treatments I'm talking about, again, are very similar to the ones I was talking about in a neoadjuvant setting. When we're talking about, I just mentioned that, maybe we give too many patients the treatments because we don't know who needs it and who doesn't. What we're really hoping to find is that we can develop what's called personalised medicine. So the right treatment for that patient sitting in front of me that day. And it is an area where there's growing research, and in particular the patients with hormone-positive breast cancer, we do now have some tests that can help us work out who would benefit from chemotherapy as well as having a hormone blocker. So they tend to be the patients who've got the more aggressive hormone-positive disease, perhaps a higher stage of disease. So in the past, I've just based my decision-making on those sort of parameters, but of course I would love to have a test like these where bits of the cancer from the operation are sent to a laboratory, and they look at what genes have driven the cancer's growth to try and work out what the risk would be of that cancer coming back. We have the tests. We have an enormous challenge in Australia getting them subsidised.
You can get a really expensive one, like $5,000.
Correct. So there's a test called Oncotype, which is the one around the world, has been around the longest, but it can only take place in the US. It costs, and it depends what the Australian dollar's doing, but it's in the order of $5,500, completely out of pocket, not a cent back from anywhere. You don't have to go, your cancer goes. Right, so the pathologist would get out some slides from the operation that were taken at the operation, and they would be shipped to the US. We have two tests that are done in Australia. One's called the Prosigna and one's called the EndoPredict. And again, they're a bit cheaper because they're done locally. So they're in the order of $3,400, which is still a stack load of money and beyond the reach of most people. And one of the things I always say to my patients, in oncology, we hate talking money. That is not why we do this job. But I need to tell my patients what options there are there for them. Well, no, I think, and it may depend on the characteristics of the cancer. For some cancers, they're just like, nah, you've got to have chemo. But if there's a grey zone and this information would help, that's when we would use it. So those two tests that are available in Australia, some patients financially are in a position they can access it, but really we want equity so that every patient has the opportunity to get the tests. There is a clinical trial open through BCT, which is the Breast Cancers Group of Australia, and in that study they're evaluating the effectiveness of the Prosigna test. This is a study called the Optima study. So if anyone is recently diagnosed, I'd encourage them to ask their oncologist or surgeon if they'd be a candidate for that test. As I've just said, this really becomes an issue of equity, these tests, and BCNA have been advocating very hard to try and get these tests subsidised, and the companies themselves have tried very hard as well. But, it's a space to watch. But clearly all of us understand that if we can save a patient going through chemotherapy, that not only has benefits for the patient and their family, but the whole of society. They're not sick in hospital having treatment, they're out in the community doing being productive. So let's go through some of the advances we have seen in different aspects of early stage breast cancer treatment. The majority of people in Australia will have a lumpectomy. Mastectomies are usually restricted to patients who have certain characteristics that mean that's what they need to do. So it might be a big tumour or lots of tumour in the same breast. If they carry an underlying gene, males need routinely to have a mastectomy, or if there's a reason a patient can't have radiation. And for some patients that's about geography. If you live 4 hours away from the local radiotherapy machine, some patients would elect to have a mastectomy in that setting. In terms of mastectomy in 2024, it should be standard of care that all patients are offered to have a reconstruction if that is what they would like to do. Many patients decide not to do that, and that is certainly, as long as it's an informed decision and personal choice, that's a great decision. But I certainly do acknowledge, and sorry, the year, I just can't keep up. The year just goes so fast, doesn't it? So it is 2024. I should try and keep up to date. The types of reconstruction that patients can have can either be their own tissue, and they are increasingly using these new techniques, either from your tummy, your back, your leg, to take some tissue and make breast tissue out of that. Obviously, implants are also possible to do. And I know that in some regional areas that, patients are not being offered at the time of their mastectomy reconstruction. In my opinion, and I'm sure everyone in this room, it's unacceptable. Oncoplastic breast surgery means that when the patient has the surgery, they essentially remodel the tissue within the breast to ensure that the contour of the breast is maintained. Chemotherapy in 2024 is still a very toxic treatment. We haven't really improved the drugs that we have available, but what we have improved is our ability to deal with some of the side effects. That is not a comprehensive list of all the treatments that patients might get for breast cancer. But the biggest challenge with chemo is the terrible side effects a patient might experience. So we have got side effects such as hair loss. Some centres do have scalp cooling. I don't know if anyone has had the opportunity to use scalp cooling. It's actually, as this image shows you, it's a technique where an expensive air conditioning unit's attached to some what look like swimming caps, and very cold air is blown onto the scalp during the treatment to try and minimise the risk of hair loss. It's not perfect and not everyone can tolerate it, but it should be offered more globally, well, certainly all around Australia. Nausea and vomiting, we're much better at managing that. Fatigue is really a hard side effect to manage, and obviously we do suppress immune system, but we've got good medication these days to try and boost your immune system to return. But what I really worry about, and what my patients worry about, is long-term complications of treatment, because the vast majority of patients will be cured of their cancer, which is fantastic. But if they're cured of their cancer and they're left with permanent burning of their feet from their chemotherapy, that means they're on painkillers and it limits their ability to exercise, then that is really difficult. Heart failures associated with some of the chemotherapy, the drug called adriamycin. We need to make sure that the impact we're having on a patient's fertility, particularly obviously for our young patients. And early menopause, while some people say, well, that's not a big deal, but if you're going through menopause in your 30s or early 40s, that is a big deal, because that's not when your body was programmed to do it. And often the side effects are pretty full on for those patients. And thankfully, it's very rare, but leukemia is a recognised complication of our treatments. The majority of people do have hormone-positive breast cancer, and that means that they require hormone blockers. And these are usually given for somewhere between 5 to 10 years, which is different to chemo, because obviously chemo is only given for 3 to 6 months. And most patients, even if the side effects are tough, it's a shortish period of time and they feel that they can hang in there. But 5 or 10 years is a very long time. And if our side effects make you miserable for that period of time, that is very tough. We have a number of different treatment options these days for hormone blocking agents, and indeed sometimes patients will move between these treatments depending on tolerability. Premenopausal women often are put on an injection called Zoladex, which essentially tricks their body into being postmenopausal, or they may have their ovaries removed to achieve the same thing, but clearly that's a permanent effect. For postmenopausal women, we typically use the aromatase inhibitors. And for men, they can either have tamoxifen, or if they have an aromatase inhibitor, like the premenopausal women, they've got to be on the Zoladex to stop any estrogen production. This is not an exhaustive list, but I think it's a pretty impressive list of the sort of things that patients can describe being associated with their menopause. You know, and I do think of recent times, there's a lot more in the media about menopause, and thank God for that, because it's really been like a silent illness for a very long time. And for patients having hormone blockers, it's like having a menopause supercharged, basically, isn't it? Because we are making the estrogen level as low as possible. And unfortunately, women's bodies love estrogen. So there's a lot of symptoms associated with this withdrawal. And this is by no means a complete list of the sort of side effects we see with our tablets, but certainly tamoxifen we know causes hot flushes, causes weight gain, which many women find absolutely very distressing. The aromatase inhibitors, we worry about osteoporosis, as well as stiff joints and vaginal dryness, which is one of those topics that lots of oncologists and patients find a bit awkward to discuss, but really should be discussed routinely. I came back from a BCNA meeting where we had an endocrinologist talking about these issues, and I decided for a day I would just bring up the topic with every patient. And I was shocked how many patients, when I actually brought it up, said, oh, actually, Michelle, that is a really big problem. And I did feel sad that it took that me being, having to think about asking that question more frequently. But we do have lots of drugs these days to manage the menopausal side effects. There's a new drug that's just been TGA approved called, not HRT, called Veoza, which is going to revolutionise hot flushes, and I'm really hopeful it will get PBS listing really soon. It's just for hot flushes, so it's a very clever new drug. But there are drugs to help with vaginal dryness, for example. It's important patients talk to their oncologist about topical estrogens if they're comfortable with them using that. There are drugs to keep your bones strong. I think lowered mood is a common side effect of our treatments and the whole cancer diagnosis, and we just need to be vigilant to notice these issues arising. The main advances in radiation are really that we are giving it for shorter periods of time. Sometimes we're omitting it for patients who have very low-risk disease, and in some cases they're actually giving radiation in the operation, just a single treatment. These are all currently under investigation in clinical trials, but I think more and more patients, particularly with very low-risk cancers, will ultimately avoid radiation therapy in the future. In terms of new treatments coming through, I've already mentioned immunotherapy. It is PBS listed for all women with triple negative disease. Basically what it does is it supercharges your immune system to attack the cancer. It's available through the PBS since last year, and there are trials looking at other subtypes of breast cancer to see if this treatment might be effective. And while it is a very good treatment in attacking cancer, unfortunately, the side effects we do see with immunotherapy is when the immunotherapy starts attacking the body itself. And this has been a very steep learning curve for oncologists. These are new sorts of side effects we're seeing, and we need to educate emergency doctors, patients, the allied health, everybody to be on the lookout for these rare side effects, mainly because they can be life-threatening. And the other exciting new group of drugs is what's called antibody-drug conjugates. These are where we take what's called an antibody, the bit in the middle here, and we glue chemotherapy to it, so the chemo is just delivered predominantly to the cancer cell. So it's a really sophisticated and clever way of attacking cancer. And finally, my talk is very relevant because yesterday, a drug called abemaciclib got PBS listing for patients who have higher risk hormone-positive breast cancer. And this is absolutely fantastic. It's very exciting, yep. I've got goosebumps, I'm so excited by it. So this is a drug that's used in combination with hormone blockers to improve the outcome for our patients with hormone receptor positive disease. It's given for 2 years.
I just took that for 2 years. I've just finished.
Congratulations. It does cause diarrhoea.
It certainly does. For anybody that doesn't know, there is a lower dose. I didn't ask about the lower dose, and that helped a lot.
Okay.
It was a nightmare for 2 years.
Absolutely. I think there is about tweaking the dose to get it right, because 2 years of needing to know where every toilet is in the state.
I know every toilet.
Yeah. There is another drug in the same family called ribociclib, which we have some clinical trial data. It doesn't currently have PBS listing, but it may also get this in coming years. And finally, just wanted to touch on clinical trials. They are a very important thing for patients to be aware of, generally comparing our current treatment with new super-duper drugs coming through. It's important that your doctor knows whether you are or aren't comfortable with the idea of a clinical trial. It's not for everyone. And often, unfortunately, it does mean moving your care to another site, where, particularly, I suppose, in regional areas where there may not be trials open. Thanks to Louise Nott, a medical oncologist in Tassie, who just sent through a list of places in Tasmania where patients can access clinical trials. I know in the past, mainly patients used to have to come to Melbourne, which seems ridiculous, but thankfully all these sites sound like they're improving their repertoire of clinical trials open to patients. Bone-modifying agents are used to try and maintain your bone health and may also have a survival advantage for patients with hormone-positive breast cancer. And finally, just a few points about living well with metastatic disease. Genetic testing is something that can be done if patients are eligible. There's complex criteria that you should talk to your oncologist about to make sure if you are or aren't eligible. The tests used to be really expensive and now they're much cheaper. They're still hundreds of dollars, but some patients elect to pay for the peace of mind of knowing whether they do or don't carry a gene and whether that's relevant for other family members as well. And finally, I talked before about these side effects, but I think moving forward, survivorship issues are really critical for us as treating doctors and allied health teams. We really need to think about, it's great if we cure a young woman's cancer, but if we leave her unable to have children, and that had been something she desperately wanted, that is a tragedy. All patients should be referred to fertility doctors if that's what they would like. Similarly, the neuropathy, mental health, bone health, heart health, all critical components of long-term survivorship. And partly related to that, exercise is becoming increasingly acknowledged as a very, very important part of patients moving forward. Patients are very deconditioned after their treatment. Often they find their exercise tolerance is pretty bad for a while, but this is something that's empowering. There's really good evidence that it can improve patient outcomes. So I really encourage patients to be looking at both a combination of core and cardio. So in summary, early breast cancer is a common, but for most patients, curable cancer. There have been recent developments, but still up to a third of patients will develop metastatic disease. And the aims of having treatment that's personalised for that patient is really where we want to move forward in 2024. We need to be on the lookout for long-term potential side effects, and we need to involve the patient in decision-making about treatments. Thanks.
Now, I know Michelle has to get on a flight, but we do have, I promise I'll get you off on time. A couple of questions. We've just got to wait for the mic. Just over here. Thanks, Anna. It's just people online won't be able to hear.
Michelle, are you aware of any trials or research on the efficacy of mini-TAM for women who can't tolerate 20 milligrams of tamoxifen? And the studies that I've seen, it's effective in the DCIS, LCIS realm, but not in the invasive cancer realm. Are there any studies that are being done just to see if 10 milligrams is as effective as 20 milligrams?
It's a great question. I talk about this a lot with patients who are struggling on their hormone blockers. So as you've mentioned, there's an Italian study, the Baby TAM study, that actually gave 5 milligrams of tamoxifen to patients with DCIS or LCIS. If only they'd had a control group and they gave them 20 milligrams, we'd all be happier. But they didn't. They just gave everyone the 5 milligrams. But if you compare those results to other trials of DCIS and LCIS, the results look similar. So there is certainly huge interest in this issue. In fact, I'm heading over to a meeting in Berlin in a couple of weeks, and I noticed a session was on should we be looking at lower dose hormone therapy for the in situ, so DCIS or LCIS. Obviously, the question is, can we get that same data for invasive breast cancer? There are trials looking at it now, but the problem with any of these trials is they take so long to produce results, but it's something patients and their doctors should discuss, because although I can't prove it, I think some treatment is better than none, and if the alternative is not being on anything and you have low-risk disease, it may be a very reasonable option for some patients.
Thank you.
Got time for one more question?
One more quick one. Your taxi's here.
I'm just going to ask a very quick one then around follow-up care. You know it's my favourite.
Yeah. So in terms of...
What should people do?
Well, look, I think, we have the big challenge in Australia, which is a great challenge to have, that we've got too many survivors for the clinics to cope with. And that, that is fabulous that we've got so many survivors, but we need to look at different models for our patient follow-up, because at the moment, hospitals can't cope with the workload. So I do think, using either a model of shared care or using nurse practitioners to do some of the follow-up is a great idea for our patients. The main thing, many patients are living fine after their breast cancer. What they really need is they've got to have that avenue to get back in quickly if things are going a bit pear-shaped, whether it's side effects of treatment or whether it's a concern the cancer might have come back, doesn't matter. And really that's, I think, in Australia, we're lucky breast care nurses really provide that avenue for most patients. So even if your appointment's delayed, as long as you've got a breast care nurse you can reach out to with issues, I think that's the most important thing.
How lucky are we to have Michelle in our lives? Travel safe back to Melbourne, and thank you so much.